We are on Facebook Live. So.
Yes, it's connecting now.
Welcome everyone. Welcome everyone that's joining us, both in the Zoom platform and the Facebook Live platform. If you're in the Zoom platform, you'll see a chat box there, and you can write your questions, and the presenter will get to them at the end. Also, if you're in the Zoom platform, the team will send you a certificate of attendance suitable for framing within 4 weeks by email. For those that are joining us on the Facebook Live platform, there's no way for us to track that and send a certificate. So if you'd like the certificate of attendance, the team will put up the Zoom link in the comments. Please click on that and join us on the Zoom platform. Additionally, we're monitoring the questions in the Zoom platform. We're not monitoring the questions on the Facebook Live platform. You're still welcome to type your questions and comments, but they won't be answered verbally at the end of the presentation. The doctor will come back in the future and perhaps type them in.
Sure, I'll put in my input there. Once I'm finished with the presentation, I'll try to answer as many as I can, and maybe I can write them down later on.
Yeah. So overall, I would encourage everyone to use the link to come join us on the Zoom platform. It's a clearer image. You have the opportunity to get this certificate of attendance at no cost, emailed to you within 4 weeks, and you have the opportunity for a question and answer. If for some reason you can't join us on the Zoom platform, of course, you're welcome to listen in on the Facebook Live platform. This is Dr. Arun Garg. I'm based in Miami, and we run the largest implant training program in the country, perhaps the world. We have literally programs 52 weekends a year. And we've expanded beyond that to invite specialists from other specialties to present, and now 28 different topics. So oftentimes 2 or 3 programs each weekend. So close to 150 two-day programs going on each year. In many industries, there's Coca-Cola versus Pepsi-Cola, or McDonald's versus Burger King. In dental implant training in the US, we're like Coca-Cola and Pepsi-Cola rolled into one. Perhaps 90 to 95% of folks that get trained through our programs. Our lectures, our hands-on workshops, and live patient. For example, if someone wants to learn lateral wall sinus lift, the opportunity to come do 15, 20, 25 lateral wall sinus lifts under my personal supervision and on patients that I provide. If they want to learn to place dental implants, they have the opportunity to come and place 30, 40 dental implants on actual patients under my personal supervision. And so with all of that, folks actually implement things. And that's what we're about, is actual implementation. When all of this happened, this crazy times in the last 1 month, and we're all stuck at home, the team and I, we thought for my alumni that I would start providing my lectures through this virtual format. And we began to do that. And it got such a positive response that then we opened it up and said, well, instead of providing it only to my alumni, let's open up to dentists from all over the world. And we'll provide the same lectures that I normally have charged tuitions for, and relatively high tuitions, and provide those lectures completely for free for all the dental community all over the world. And once I did that, because over the years, I've had the chance to meet and become friends with so many key opinion leaders from around the globe. Many of them contacted me and I contacted many of them. And everyone wanted to join this platform and said we would be delighted to share our information for free also. And about 95% of the top 100 to 150 key opinion leaders from around the globe joined this effort. About 5% sat it out, but that was a very small minority. And the other 95% said, we're going to share the same content we do at major symposiums, not delete every other slide because it's free, but give all the content and share truly from the heart with no commercialism, no product sales, no company endorsements, just actual science and actual clinical techniques. And so as we get ready to start going back to work, then of course we're going to phase these out. But for the time being, we're continuing this. It looks like most of the country, most of the world is starting to go back. You can imagine for the team, it hasn't been easy to coordinate 150 speakers in 24 different time zones, coordinating participants in 24 different time zones, learning this virtual platform and the technology behind it and running that in the background, and all with no income coming in for any of us. And they've got the same fears of Corona that everyone else does. They've got the same financial issues. For now, I'm paying them, but they don't know how long that will last, depending on how long this drug's out. So with all of that, they've done a fantastic job in the background, putting all this together. The speakers have done a fantastic job. The participants have been phenomenal. Is coming in and learning and putting in excellent questions and excellent participation. If you have a chance, please like. If you're on the Facebook site, or like our Facebook page, follow our Facebook page, share our Facebook page, and then we can all continue to grow together. Doc, I'm going to turn myself off and turn everything to you. Okay, Dr. Lamba?
Thank you.
Okay.
Hello, I'm Dr. Abhay Lamba. I'm speaking and practicing in New Delhi, NCR region in Faridabad. I have my own private office. I did my graduation from Manipal College of Dental Surgery in Manipal. I did my master's there and had the opportunity to learn from Dr. Arun Garg some 17, 18 years back in Spain, and attended his sinus lift course there where he was teaching PRP and its influence. And after that, I kind of became his student, and I started reading his books and articles, and I learned a lot from him. Thank you, Dr. Arun Garg, and bringing all the speakers and delegates and doctors of the world, dentists of the world together on this platform and doing a great job. And it's an opportunity to learn and share, and I hope so put in my penny into it. My experience, I started my practice in 1999, implant practice, and since then I heard a lot of speakers. I trained under a lot of mentors and experts, and putting my bits here and there, my experience. And if I quote Dr. Swami Vivekananda in this, the knowledge can only be get in one way, the way of experience. There's no other way to know. And I think that's the right way to go ahead. And this is my way. And I'm sure I'm going to give you one or two tips, definitely. This is my college, and I got my first diplomate in 2015, ICUI from lead Dr. Kalmish, and it was a big boost to me. And now I'm do a lot of CERAC thing in my single visit dentistry in my practice. I'll share a few of my experience with you, my journey of immediate implant and immediate restorations. This is my small team which works with me. And now it's a little bigger now. We are 16 people there in our practice and a few doctors. And this is my initial picture when I started my in-house labs. So before I start, I just want to touch on what is the reason and what made us to do immediate implantation and a mechanism of immediate loading. Here, I'm not going into too much of theoretical things, but if you look into it, the more important factor is we have to understand the immunomodulation, how the bone works and how the bone heals. And the host response to the moment we place an implant, and the titanium, how it touches our bone, it disturbs our immune or host response and leads to the attraction of monocytes to the implant surface and leading to macrophage formations. And we have two type of macrophages there, M1 and M2. And normally how we put it in physiology there, M1 is pro-inflammation and M2 is pro-new bone formation or osteogenesis. So here, the way how we do the implant placement and what kind of coating there, or it expresses accordingly. And titanium with the calcium or coating, it's forms a faster new bone formation, reduces the inflammatory response on macrophages, creating less of osteoclast or more of osteogenesis there, and the repair formation starts there. And normally when we have an impulse also, if we load it or a micro movement starts there, it's our impulse there, it's also initiate the new bone formation. The mesenchymal cells which are derived from our bone marrow and present there in maxilla and mandible, and they enhances the new bone formation there. It excites the macrophage formation, M2 especially, and it downgrades the M1 macrophages formation there. Now, another advantage to us is once the implants, how we look into the modern implants there's a lot of change in the design and topography of our implant surface. And they have become more hydrophilic. And they lead to a faster vascular growth factors to form more vascular supply, or as angiogenesis around our implants. So higher vascular supply around our implants, leading to if you do immediate implantation. There are the few factors which forms immediate implantation, immediate loading a reality there. So I'm not gonna talk too much of theoretical part into it, but I'm gonna discuss a little bit of the factors, the main factors there. That is the primary stability, which we have to achieve. Then second, which is pro-angiogenic surfaces like hydrophilicity and coatings, and topography, the kind of surface threads and surfaces, how rough surface is available for bone implant contact. And then we have to look into the physiological factors. So if I look into the physiological factors, the more important part is the condition of periosteum, how we deal with it. So if we maintain a traumatic implant placement and we maintain the integrity of the periosteum, that means we are maintaining the vascular supply to the cortical bone there. So that's then one is there. Second thing is the volume of bone around the implant. So viability or availability of viable cells for change into, or mesenchymal cells to release growth factors there. That's also important there. If you have less bone there, that means less viable bone around your implants. That means less growth factors available for new bone formation. So you need a more sufficient amount of volume of bone around your implant. Type of bone. If bone is a vascular bone, obviously you don't have much repair happening there. So immunomodulation gets compromised if you have less or a vascular bone there. So these are the certain physiological factors we have to keep it in mind when we decide to do immediate implantation there. So if anything is lacking, we have to compensate, or we try to create more volume of implant, or create more vascular bone around our implant. So if you look at the literature or evidence which is available to us, we had first study in somewhere in 2003 where we were doing overdentures. I remember my college days when I was learning implants under Dr. Peter Blydrop and my college team there. Dr. Hurtle, R.C. Hurtle was first mentor I had. And we did first case was overdenture cases, immediate loading cases in mandible. And that on 4 implants, and we're giving them a partially removable overdenture implant supported. And as we go by slowly, we have more evidence about, and if we, as we climb to think, we had uh, tilted implant protocols coming in around 2010, and later on we start doing in maxilla also, and nowadays we do immediate restorations, not even immediate implants, even in on a I would say segment wise. I'm going to share a few cases to support that. And if you look into the studies, seeing looking into how effective these implants, immediate implant as compared to conventional implants are there. If we look into this study by 19 clinical references we have, and about nearly 2,000 cases were done. Into that short term, if we look into it, it's about 6 months to 1 year. We have nearly 97% to 100% success rate. And if we look into the midterm, 3 to 4 years, we have around nearly similar kind of success rate. And as we look into the long term or longitudinal, let's say about 5 to 10 years, we have nearly 98%. And maybe I'm sure that we lost some cases due to overloading or some underlying disease there. So in our 5th ITA consensus, we have literature says it is as predictable, maxilla and mandible bore up as predictable as conventional implants. So if I showed you this case with the data available to me, that I just talked about physiological factors, and this case was sent to me from one of my colleagues, and I found rocking implant in the left sinus and some implants with tricortical support. That means it has a crestal cortical support plus the floor of the sinus, then the lateral wall of the nose on the right side maxilla. So these cases were done without training. So it's like if you do not have a good mentor or teacher to guide you, only literature doesn't help you there. And similarly, this case implant was moving up and down. And this case is on the lingual cortex, and this implants on the buccal cortex, and this was in the mental foramen. And this case, when it was placed, there were actually 2 more implants, and patient was given immediate overdenture over it, ball and socket. And this was actually a training program course, and where the surgeon was training some PG students. And this is about nearly 10-year-old case, and within 4 or 5 days, 2 implants came along with the overdenture, and 1 implant got lost in the sinus, and the patient was in pain. He tried to go to the same doctor, but there was no treatment was given to him. So I have to retrieve all the lost implants, and especially here I placed a block graft there and some xenograft there to just to keep a late resorbing bone graft there. And then I later on, after 6 months, did some sinus lift, grid splitting, and placed some implants there and gave him the option there. This I did in somewhere in 2010-11. It's still holding fine. This X-ray is 2018 when the patient visited me. Looks fine. I actually lost 1 implant when he visited last time. The upper distal most implant on the left side. I have to remove that implant and place the bridge back in and recall the patient to come back again to get his, some more implants there. That time I was not aware of tilted implant technique, it was still not very much recommended. And this is later on, after 2 months he came, but then he went against, he doesn't want, he said he's comfortable and he doesn't want another implant there or anything else to be done. So if I look into the evolution of immediate protocol, so what is we are looking at implants is the primary stability by apically tapered implants or fully tapered implants. And we are looking at the secondary stability, we are looking at the hydrophilicity and the topography of the implant surface. And in the prosthetics, we have different flexible options we have. Abutment, if you look into it, we have platform variety, like we have platform switching and other things. Straight and angled abutments, gingival height variety, plan abutments, which is CAD abutments. Then we have temporary components. We have temporary cylinders there to do immediate loading with some PMMA or composite prosthesis. We'll be talking about this at a few of my cases. And then we have a different impression lab components there. If you look into the workflow of these materials, which is now available to us, especially the prosthetic materials, we can divide most of our workflows into types. One is analog type, or other is a digital workflow. So I'm going to touch a little bit of the digital analog way because I don't practice it anymore in my practice. I have completely shifted to digital protocols now. Since 2015, I'm doing mostly digital work, and I find it very convenient for my patients and myself, as well as it's less cumbersome and less messy. So I'll discuss a little bit of analog also, because I don't think so everybody has digital workflows available. You need certain equipment for that, and slowly I have acquired in my practice. I hope so. Most of the world, I think especially in America, we have most of this equipment available in the office. But whereas in India, we are still dependent on centers, radiological centers and other centers. I'll explain that. Then we have some biomaterials also. And these materials, I'm going to talk about different materials for framework, how we can use those materials to look into certain conditions like parafunctional habits, or some people who really have a heavy bite. And certain regions, like in India, especially where I practice, we have patients from a hilly region or a mountain region, or more from the people of North. They eat a lot of heavy food, or they chew, or say even the meat, they have a dry meat or dry cheese, and they have a lot of load onto it, which is leading to some fracture component in the framework or some implant failures. I'm sure in America you have steak is one of the routine or regular or staple diet in certain states. So I'm gonna touch a little bit on the materials also, that we have a new age materials which really supplement or complement our protocols. So this is a simple flow chart, and we have to have medical history. I'm not going into it. We know what are the contraindications, they remain the same in these cases also, and especially nowadays because of bisphosphonate, we have to go into it more deeper into it, because that's where we have little still a complication there, which we have late implant failures also coming in those cases. So I have certain experience of cases where the patient was using bisphosphonate and they stopped using it for 2 years or so, but still they had a little repair impairment in the bone, so that lead to implant failures. So still medical history is very important there. And then we have to think exactly, we have to understand or diagnose the issue of the patients, and accordingly we have to see how many teeth we're gonna save, or what patient comes into which category of soon to be dentulous case, or we can retain certain natural dentition there. Accordingly, we do the 2D or 3D imaging, and we decide our kind of processes we have to design. Once we are sure and we have discussed with the patient about the design of the prosthesis, what we need or what he consent to get it, so we decides to go, and obviously we have to look into the financial implications of the treatment also. We cannot give everybody the same what we want to give. We have to keep patient confidence also. So if I look into the traditional, we normally do a conventional pen, or OPG, and then we do 3D scan, that is CBCT scan, accordingly, because if we are planning to do a full mouth rehab and we have multiple segments to restore, I would prefer to take a 3D or CBCT. And normally, to plan a treatment, OPG is good enough. So when I'm planning a treatment and diagnosing a issue there, a prosthetic issue, or to discuss my patient, give him an initial planning to my patient, I prefer to take only OPG. And a patient convinced to that, then if I have to plan a treatment, then I would like to do a CBCT. Then we have a freehand surgical planning and normally in traditional way. And then we do pick up the processes and we make some uh, temporized or temporary process in advance. We convert it, we pick it up, use certain uh, composite or dual core material to you pick up the processes and clean and polish it, adjust it, and we normally screw it in or we according to our friction fit or whatever we have decided. And provisional process delivery is done normally in the day one. Then we have to wait for about 6 to 8 weeks, and then we pick up a final impression. We see how the soft tissue come up, and then we do a traditional impression, and classic way we go with the processes fabrication after jaw relations and everything. Now on a digital aspect of it, it's a similar till the diagnosis and planning. And then after that, we do planning here, not on the models. We take not the conventional impression study models or study cast. We normally take digital impression. The planning and everything is happening on the digitally on the software. And we do a surgical guide also planning there just to ensure that we have exactly the same orientation and placement of implants inside the bone with nice viable sufficient bone around our implants. And then we can decide the kind of prosthesis or prosthetic components we need there. So we can even pick up the prosthetic components in the planning itself, and we plan a temporary in software itself. And we can 3D print it or we can mill it and keep a little temporary processes ready before we really do the surgery. And then we do actual surgery, and then we go a provisional processes delivery there. So I'm gonna do a little bit both sides. I'm gonna touch. I'm not gonna touch much on the traditional one because I think everybody is aware of it and seen it. This patient walked into my clinic long time back, and I think in 2013-14 the patient walked in. She was my colleague's medical colleague wife, and she was taking certain antidepressant drugs. She stopped talking and stopped eating food, and she was ashamed to talk to somebody. She was feeling very conscious. She was not even coming out to greet any of the relatives or family friends visiting them. So she was sent to me, and this was a situation there. And if we are looking at these three bridge there, even this was shaking because the central incisor was fractured. So after looking into her CBCT or 3D, I found certain issues with the other teeth also, and there was no way any of the teeth need to be, especially the right side molars were fractured. Central incisor was fractured, 1-1, or upper right central incisor, and the premolar was fractured on the left side. So this was a situation when I looked into it. That was the central incisor as upper right incisor, and this was the canine, and this was the premolar. You can see it's fractured there. So I decided to remove all of them, and this was a cast, and we did a little bit homework there. That means we did a little wax up, and we prepare shell. I was using shells there, and use a putty impression there to keep my shells there, and sandblasted them, joined them together and made a little pro shell there. Then I decided to place 6 implants there, first to restore the maxilla and then mandible. There were 2 tilted implants distally. After the extractions, debridement of the sockets, placed all 6 implants and 2 tilted implants, that's the both left and right distal implants were tilted about nearly 35-degree tilted mesially and palatally and medially. I used a little bit of bone I harvested through the sockets, mixed it with a xenograft, and placed on the buccal side. As you can see, this implant is tilted about 35-degree more mesially as well as anteriorly. This particular socket was kind of little, there was a big deficient facial cortical plate. So I put some membrane there and some bone graft material there to keep the jumping distance in control. And these were the fractured canine. As I've shown you in the CBCT, as you can see, it's fractured there. And sockets were closed. Then I used multi-unit abutments to make them all parallel. This was done freehand. There was no guided surgery done. Then I used intraoral welding there, and just to create a little rigid prosthesis, so there should not be any micro movement, and created a little bar. And you can appreciate the screw holes are coming exactly where I wanted to. But this was a little tricky and quite stressful while doing the surgery. And this was the temporary prosthesis given there. I picked up the impression, or I can say my ProShell. I used a dual cure composite material there, and it was gum in color. And I picked it up, finished it. It took me a whole day to do that. And this was finally in the evening, the patient received it. This was a bite. And she was quite happy. And later on, she came back and got it rest of the treatment done. And this was the final picture, as you can see here. Multi-unit abutments, screw retained prosthesis given. It has a rigid stability or splintered prosthesis. It worked out fine. And this is later on. So this patient later on received other ceramic bridge also, and it was working fine so far. But this was a little trouble, or I would say a lot of messy. I had to work it twice. I had to pick it up. It's kind of really, you need a lot of experience to do that, especially if 1 or 2 of your implants doesn't get into a good primary stability, then it's a problem there. And 2 of my implants there were not stable enough. If I go into this, the canines were not primarily stable there. Though I did got some cortical support from the nasal floor here, but still it was a long implant, so I had to get the stability there. Earlier I planned to place 11 mm implant, but end up placing 14 mm to get a little bit of primary stability with no facial bone there. So in that case, I was forced to use a welding technique there to make them stable there. So it's sometimes very tricky. In some patient's mouth, when you do that, it's really gives you a little firework there. So patient feels scared. Nothing happens, but patient feels a little bit scared what is happening and why welding is happening inside my mouth. Now this protocol, now a digital protocol, which was introduced in my practice in 2015 onwards. I was doing a little bit, but I was getting the surgical guides made from outside. And when I was placing in patient's mouth, I was not getting exactly what I really wanted. There was always some discrepancies here and there. Now, before I get into that, I'll just explain how it works. We have a pre-op planning. We normally take OPG again, and we just look into it. Then we do two kind of scans. One is intraoral scan. That is, we use intraoral scanners. We take a digital impression, and then we take one CBCT, or a digital or radiological scan. And then here in the digital impression, we normally do a virtual planning there. We remove the teeth and we add teeth there, and we make a setup there, and we check the occlusion with a digital articulation there. And then we superimpose this onto our radiological scan, which I'm going to show with my cases there, one or two cases, just to make it people to understand. And then we do a guided surgery. Simultaneously, that the virtual planning what we have done on digital impression, we superimpose on our digital scan of implant that we have placed after the guided surgery, and we save our first plan as a catalog, and we superimpose it, and then we mill it. So it takes about 30-35 minutes, or if we 3D print it, it takes about 1.5 hours. We give a break to our patient, and then we superimpose or pick up on our, we can do it in the mouth, or we can pick up an impression, and we can do it on the lab side. I prefer to do on lab side because easier, because my technician's working on it, and I'm working on my another patient. So this is how it works, and later on we the same scan, we design our framework, and when a patient comes for a checkup after 6 or 8 weeks, we pick up another impression with a new soft tissue level, and then we plan it accordingly. I'll explain with the case. We need certain surgical kits for that. We have few of them, a few collection of them. Some has plus points, some have their own cons there. I'm not wasting time. It's all everybody's choice to choose which system they want to use. I think in today's modern implantology, every system we have is having their own surgical guides and surgical kits available there. Now what's the benefit of doing guided surgery or digital protocol? This improves the quality of life, definitely. It's any kind of dentistry, we improve the quality of life of our patients. And in this also the same thing. It improves the aesthetics and phonetics of our patient. And it's a less complicated procedure. Patient doesn't really see what is happening, and he gets the teeth out of the blue, and let's say he's pleasantly amazed to see his bite is restored within 1 day. So I'll just explain how it works. We just take a small cut. We can use actually here rotary blades, or we can use BP blades. We expose the bone. We use flat burr. We remove every debris or flatten the ridge, and then we do the pilot drill. Thus, with the guide, and accordingly, we step by step we seal it. So I'll explain a little bit. We put again surgical or guided surgery here. We have sleeves there. It ensure that your drills are going exactly how deep you want them and which orientation you want them to be there inside the bone. And that explains the thing. These are different steps with the different systems, and you have to follow step by step. And here also we have an option of customizing our abutment as per the soft tissue profile in posterior and anterior. And we can have different designs. I'll explain few of these with my cases. We can have different kind of materials. We can have a different customized abutment materials, and accordingly, depending upon the occlusal load, we can change our prosthetic material also. So I would like to not go into this theoretical part into it. I would try to explain you with the cases and how we customize it. The different, you need a special kind of blocks there. We call them meso block, and they comes in two sizes, S and L, depending upon the abutment size or scan post what we have for the respective implant system what we are using. These are for interiors. We can have more aesthetic looking glass. We can use it here. Lithium disilicate, we can use it here. Feldspathic or other combinations are also available. They are also available in mesoblocks. I'll explain you the cases. These are for the temporary restorations. They're mostly made of composite material or PMMA. And this is how we use this is a very important component here to take a digital imprint for the implants. In a restorative phase, we call them scan posts. They are for a different system. We have different calibrated scan post system. Both are available for tissue level as well as the bone level, or sorry, implant level. We can discuss about with the cases where and how we use different. So digital impressions have a lot of benefits over it because we can use it, we can modify it, cut it without any blade or without any, say, plaster or dust, and it's more hygienic to do that. And we can save this model, we can print this model, 3D printing. It works out cheaper, and a lot of advantages of intraoral scanning. And I would advise, we have a lot of advantage nowadays. We can even post and core also we can do it, not only implants. I'll start with a small case where I've used immediate loading, customized abutment with temporary crown immediately, aesthetic looking temporary crown made of composite material. This patient is a nice young lady about to enter college. She was very conscious about her gap in the front tooth. She was wearing a gum stripper for that so long because her orthodontist advised her to wear that gum stripper, and once she's her lateral growth is fine, closed, then she can go ahead with the implants. And they never wanted a bridge to be done, so they were highly motivated and educated by orthodontists. So I really appreciate that. And when I had the OPG, I had a little trouble there. There's hardly any space there, and I asked my orthodontist if he can create some space for me. He was a little said not possible. I have to do little proximal stripping, and she has to undergo certain um, duration of time. Means another it's gonna take about 8 to 10 months for that. I was little disheartened. The lady was also disheartened. I said, okay, let me get a 3D scan done if I can help you there. And I did a 3D scan. So if I look into it, I had a sufficient bone that was 4.3, and that was also fine. Means the height of the bone available was fine for me to place a good length of implant there. Except a little bit bone expansion I have to do here if I look into it, and the implant, the available bone was a bit less, so I have to go for a narrow neck implant there, and I decided to go for a guided surgery, so not to impinge into any of the periodontal space of the adjacent teeth. So I did a digital impression, and I planned my tooth and superimpose it on my CBCT in a planning software. And as this ensure that my model is been superimposed nicely over my scan, and I started planning. So I decided and took from my library and many different systems, and I see if this system works fine. So this gives me a nice sufficient secure space all around my implants. So this was selected. Then I selected my abutment. So I will be needing about 15° and about 3 mm height should be there, gingival height. So that abutment was selected. So I checked into my inventory. I had this 3 mm abutment there in case I had to give the patient immediate loading with a temporary crown. So I kept one customized, or I would say stock abutment there, and decided to go for a narrow sleeve, and decided to go with a CEREC guide there. Fabricated my guide, design, sleeves, positions, and I saved my file and sent it to my other machine where I can design my surgical guide. So I saved it, and this was the abutment selected, and save the file and the planning, for the chair side sticking and took it to my other software. Here I selected the software, immediately opened the saved file, and I selected the extent of surgical guide I need, because it was a tooth supported surgical guide I was planning to do here. We have many different types of surgical guides. We have tissue supported, we have bone supported, and we have tooth supported. So for individual or one or two, or when we have dentition, natural dentition available, normally I use tooth supported because easy to make, easy to stabilize, and it works out economical and faster to do these kind of surgical guides. Brings the cost also down for my patient. If I need to make a bone supported, that is also possible, and I can also make completely dentulous cases also tissue supported. But that's another presentation where we can come again to do that. So I said this is my virtual implant position here. According to my plan, decided my surgical guide thickness and the materials and the sleeves. I decided to have a facial opening slot there, and I decided to have this much stability is good enough. So there was no red point, no undercuts. My software decides this works fine, and I save the thing. Now this surgical guide, I can mill it or I can print it to according to the cost what I need. Here I'm using Galileo's from Dentsply Sirona, and you can use even Exoplan from Exocad, and we have other planning systems also from 3M. Also we have other surgical systems also available for these kind of software to plan surgical guides or implant planning. I think KStream also has come up with the software. I have attended one of the presentation there about 2-3 months back. This also can be useful to make these guides. And yes, you can have a complete control over it to plan these guides. And yes, it has a little bit of learning curve, but if I can do it, anybody can do it. Now that's the virtual planning, everything done, and then I checked my surgical guide fitting and the sleeve fitting there, and it looks fine. The narrow neck implant which I've selected, narrow neck, it was 3 mm implant, and 11 mm was the length of our implant. So I've made the cut here, and so I prefer to use a rotary blade to cut it, and selected my implant and inserted my implant there. You need a special drills to do that. It has to come from your guided surgery. Placed my implant as deep exactly how I wanted it to be inside the bone, because virtually I decided, selected my abutment also in case I'm not able to pick up a digital impression. I picked up the digital impression, make the customized abutment with zirconia. It was easy for me to make it because it's one of the cheapest component to use as a customized abutment chair side. I made it in about 30-35 minutes. Took me to cut and center. Check the fit, and also I made the crown simultaneously. You can design a crown after a digital impression and split it, and then you can split that design into a abutment as well as in a crown. And two different material can be used to make a complete crown here. Abutment component can be zirconia or glass, or your choice, or physiological material. You can use even by HPP for that. And crown can be of glass or can be of, I would say, a temporary material like composite or something, or you can modify it to mold your or shape of your soft tissue. So I did this. Then this was the case there. The crown, I was not too happy. It looks a little bit bulky, so I decided to make it later on, but that I wanted to finish this case, so I gave it a temporary crown. And this was while the crowns were cutting. I took an x-ray just to check if my implant is nicely in a safe distance from my adjacent implants. And yes, I was lucky. I was able to place my implant. And then the patient came back after 6 weeks The soft tissue healed very nicely. Papillae walked into the space, interdental papillae, and this crown was patient got changed into a lithium disilicate or a glass crown. And this was when patient came back to me after about, say, 6 months. This looks fine to me. Soft tissue is healing nicely. A little bit of little plaque there, but otherwise looks fine to me. And this was after 6 months of final restoration. So this was a little bit of, I took a CBCT to see if its apex was looking a little overlapped here. So I checked into it. There was a sufficient gap or space between periodontal space and the implant surface. And this was the 3D image of my implant, nicely inside the bone there, nice volume of bone around the implant. And this was the grayscale image of, actual image of my implant. This is another case. I'll try to explain all the features and steps with each and every case. So this was a case, this was my first case where I planned to do a guided sinus lift and guided bone expansion. So I wanted to have my implant placed in exact position, because what I was feeling when I was doing a ridge split or bone expansion, normally I don't get the primary stability exactly where I want. My implant normally get either more palatally or sometimes more buccally, though we can compromise it with our prosthetic adjustment there or customized abutments, we can do that, but I wanted to make it more precise. So this is another good patient of mine. She had a little edentulous space there, and I wanted to restore it on the same day. So I given a local anesthesia and did a digital impression, mark on my software in digital impression the site where I wanted my implants to be there. And these are marked as cervical lines there, and my computer makes or designs the crown there. And these crowns are virtually made by the software, and then either I can make these crowns as a temporary, and or I can save them as a catalog in the library of the same patient. And when I take the final impression of the patient's mouth after I place my implant and I use my scan post, I can superimpose this design over it, so I don't have to waste much time. And as per my abutment design or prosthetic abutment design, these are milled by my software. So my process is also ready in the same day. So this was the condition of the case. Hardly any bone there, but length was favorable, height was available, and posteriorly the situation was width was favorable, but length was a bit less. It was about hardly any 4 mm there. So I decided to do a indirect sinus lift there and crustal approach. So I wanted to do a guided sinus lift there. So I decided to do a surgical guide planning there. And here again the same steps, superimposed it, planned it, and accordingly I've place my implant position there. Now, as you can see here in the orange shadow or outline, you can see that there's hardly any bone on the buccal side and lingual side. My implants are actually eating off all the bone available there. And this is my virtual crown position or orientation there in the as per the occlusional plan of the patient. So this is decided. So here my implant, if I place in this angulation, was coming at the cuspal or buccal cusp. So that's not an ideal position. So I decided to make a customized framework with the individual crown there. So where I can put a abutment there with the crown cemented over it. So this was the implant placed there. They look quite parallel to each other, but they are not parallel. One implant is absolutely straight, and that anterior implant or a premolar is more palatally placed. So just to have a different path of insertion or so give us a little cross stabilization there. Save the file again and decided to make a surgical guide accordingly. So here the drill guide will only drill till the floor of the mouth, not beyond it, in the second molar region. And this was decided, and I made a slot here because posterior you have hardly any space, so you can bring in the drill from the side. So this was the bone available there. I made my pilot hole. I'll go back one slide back just to show you what is there. It's like I made an initial hole and did a bone expansion there. Placed my implants there as decided. After the sinus lift, I placed some bone graft and inserted the implant the same. It was exactly how I wanted it to be and sutured it back. This case, I kind of didn't get a good stability, but I planned to do a little immediate restoration there, but both the implants were not primary stable, so I decided not to go. Sometimes it doesn't work, but I did a plan, I did a digital impression, and I planned my framework here. So I made my bridge plan here, cut the zirconia framework, and then also cut my crowns and sintered it chair side and did the layering there later on. And called the patient after 6 weeks, placed my framework and the crowns there. This was one of the only cases where I planned and didn't go well on the same day. But the outcome was really nice. I was happy with the results there. And this was the healing happened there. And this was the bone around on the interior implant. So this was the angulation what I wanted to come in at the cusp. And this was the final results. And this is post 1 year, post 2 year. So it's working fine. So this case I did a long time back, immediate implant placement in patient's mouth, freehand obviously. He was diabetic, so I removed upper dentition and placed my implants there. This is I think done in 2002, 2003, and then I placed a regular as per the training and the treatment modalities available that time. I did the restoration. But now the question here is now the lower teeth as they were failing. There was a fractured premolar here. The tooth was failing here. This tooth is shaking, and this side, both these teeth were mobile, the premolars. So this was a digital scan done for the patient, and planning was done. This was the initial photographs. So here I plan to do a tooth supported guide here, and I kept the existing teeth still there and plan to place implant in 7 and then on the premolar, and plan to do immediate loading. So this was a digital scan of the patient. I made the cervical lines here, removed the tooth virtually here, and then again I replaced it with the material using software. And here I made the surgical cervical line here and here. So I've decided to have 2 second molar implants there and 2 on the first premolar and a bridge. So occlusion done, minor occlusal adjustment done, planning done, save the file, cataloged it, and then I superimpose that file on my CPCT and plan my implant position and orientations, sleeves, abutments, everything here, and this is documented here. So this radiological measurements were there to help me decide the size of implant and orientation of the implant, diameter of the implants, and did the implant planning. So this was the implant planning, final implant planning after a little bit of modification, because my first planning, my milling decided not to do it because there was 2 angles which are coming undercut was beyond my 5-axis machine to mill it. That time I didn't have a 3D printer, so I had to change my planning a little bit. So this was accordingly, we changed a little bit of planning here, the molars. Placed my implants there and save the planning. Sorry, I'm going a little fast because this already been covered. surgical guide fabricated as the same how I showed you in the last one case there. Straps were used, thickness and slots decided, and then I milled the surgical guide. I use this material which is PMMA, and it is autoclavable and available. It came for a trial to my office, and I used these sleeve and sleeve surgical guide there. And place my guides, use the anterior teeth as a support there, and then I place my implants, picked up the impression there. So this was the impression which was picked up immediately after the surgery. Still there's some suture lines here. Then I use my catalog planning, what I've done on my initial planning, and on the cylinders which I've, as per the occlusion, I cut them to the right sizes and then sprayed it and scanned it. The catalog which I've saved, I've superimposed it, correct little bit of occlusion planning there, and then I've designed the processes. And later on I splitted it. So the same framework was splitted into a framework and a crown. And I milled the framework and cemented on my cylinders there. And the crowns were made. And the crowns were made in a HIPC material, that's the high impact polymer polycarbonate crowns or composite crowns, and cemented it. And this was a little bit of used gum colored composite to give a little more aesthetics there. And this was the temporary ready, and I placed the implants, abut bridge in the patient's mouth and check the occlusion, correct a little bit of prematurities, and made a little more anterior load there. So was sent, and later on the patient came back after. This was the x-ray immediately after the surgery. All looked fine to me. And this was later on. I did same framework, and then lab composite, build it up and give them the patient the final processes after 6 months. I think I've overshot my time. This is another case. Patient had a fractured tooth hair bridge. This patient is actually having some implants here and there, and she was a patient for implant cases. So I've gone through that. And she was a patient in my office for implant training courses. So different systems by different doctors have been done. Planning was similarly planned done. Same steps: implant planning, sleeves, surgical guides. So here, because the patient has only one side occlusion, and she wanted to have the other side later on, so I plan to place 2 implants there and splint them immediately with some physiological material. So if some overloading happens, then that material should fracture, not the implant. The impact should not go on the implant. So these were the steps. And 2 implants were placed, scanned, impression was picked up with a scan post. And as you can see here, 2 digital impressions were picked, and 2 PMMA crowns were also made, a bridge, and 2 customized abutment was made in bio-HPP on tie basis, cemented in the patient mouth, and then I made again a simple PMMA crowns. I cut it chair side and cemented over it. So this was here I was having a good primary stability, and I was planning to give the patient a softer material there if to absorb any occlusal forces there. So this was done and restored, and post-loading OPG was taken, so it looked fine to me. And you can see a thick cement layer in between just to um, have a poor retention there in case of overloading, and the bridge should come out or break. This was the close view, and one single segment was loaded chair side on the same day. And later on, the patient, sorry, I'll go one slide back, and the patient came after 6 months, and we just changed the crown bridge. Again, the new bridge was given on similar crown. We used a composite bridge rather than PMMA. Now, patient is still thinking of getting the other side done. Doesn't want, she's fine eating on that side so far. We are just still maintaining that way. This is another immediate loading anterior upper teeth. This patient had a anterior teeth, multiple time endodontic treatment done, some seepage of pus coming out of pocket. We lost all the buccal bone there. It's a high, how to say it, she's a dentist and she wanted the tooth back in there. So I had to do it on the same day to help my colleague. So I did the planning here, and according to the planning, I thought of taking or utilizing a little bit of job on there, stabilize it, and some graft material there, and save the planning, and decided to go for a immediate function. Made the surgical guide the same steps as I explained with the first case. I'm going a little faster. I'm really sorry. I think I lost track of time. And I decided to have a extend of my surgical guide here in this software. And then saved my guide. So this was the surgery done. I removed the tooth and debrided the socket nicely. Used my protocol of placing implants in acute infected sockets or chronic infected sockets or inflamed sockets. I have this protocol. I'm using it since 2006, and with great success. I tried to present it in Frankfurt University, but somehow my health didn't work out, and I couldn't finish my clinical trials there. But still works. Maybe one fine day I'll present it once again. So this was, I did very conservatively raise periosteum there, and placed my implant as per what I wanted there. I got a good primary stability there. Placed it, slightly submerged on my implant, used bilayer biomembrane there on the buccals facial shelf. I placed it, stabilized it with bilayer technique, and placed some xenograft mixed with a little bit of whatever I could harvest, autogenous bone there, and followed the Bruiser's technique. Slightly used a vertical locked sutures to decrease or somehow reduce the tension of my flap there. Pick up an impression, use a guide there because it was a little deep, so my impression post or scan post was not really getting scanned by my intraoral scanner. It was an old type. Now I have a much better type. So I used a normal crown, temporary crown bridge material to index my abutment impression post and picked it up. Made a virtual surgery on my study model using the same guide to have the same position there, and place some pattern raise in there, stabilize my abutment position there, design my abutment, mill it nicely, the stock abutment BioHPP abutment there, scanned it, and made the crown. I kept this crown slightly out of occlusion and active function, made it in a PMMA composite material, and I cemented it. Patient was sent home, and this was the bone graft here. We had a nice stability from three sides, except the facial side, and this was the situation when the patient back in IOPA, and this patient came back after about a week for suture removal. The soft tissue looked fine. I was curious, so I just picked up another OPD just to show. And this was CBCT after 2 months. So nicely, bone was formed there, vascularized bone there. Looked fine to me, so I picked it. This was the soft tissue healing around the tooth, so looks fine. Then I called the patient after 2 months. I just wanted to be sure to see if the bone is stable, and this bone is post 4 months. It's quite stable, so I decided to go for a final crown there. Sorry, do I have a time to take one case more? This was a dentulous case, and so, gentlemen, senior citizen, my patient, fed up of his denture, wants something fixed. He wants to eat. In last of his days, he's 82 years old, and pan chewer, has habits, smoking, and controlled diabetic. So I started with this, and I made the temporary. I made a cataloging and milled a PMMA framework, and then I used a little bit of tooth-colored composite to mark it. So for my surgical guide, I did similar virtual planning and adjust the occlusion, and then I did a little composite, gum-colored composite to just to look like a bridge or a denture. So I went ahead, and this was for the lower one, so I couldn't finish the lower one, so I just made the framework, not the gums, but this were the four implants were decided to do a immediate loading. So this was my processes ready before the surgery. Made the surgical guide, upper and lower. The lower one was a tooth supported one, and upper one was the tissue supported one. This I made a protocol, passed it, it took me about, this was my first case to make a tissue supported guide from Galileo software, and I made a protocol. Maybe one day somebody wants it, I'll share it with people there. And I made I superimposed my cast or impression, digital impression of my cast over my CBCT, and decided to place two implants. Here I decided to make implants more into engage into the palatal bone for the posteriors. I'm using here is ultra short implants of 5 mm diameter and 5 mm length there. And on my anterior, I want to have bicortical support. So I used a canine support here. I am going from palate to the buccal or the canine fossa here to engage into the triangle of my cortical bone here. I'm not tilting my implant more mesially and palatally here. I'm tilting my implant more buccally. I would say more of a zygomatic or partial zygomatic approach here to have a nice long stable anterior implants there, so they can support my short posterior implants, because I never wanted to do a sinus lift in the posterior. I was planning to do immediate load here. So here I use tilted implants in the anterior, which is going from palate to the more outwards toward the buccal cortical plates, and two ultra short implants in the posterior, which are wide implants. They are 5 mm wide and 5 mm long, more like a hand grenade. So the planning done, that was for the upper ones, and lower ones were the normal 4 implants as it should have been. Regular size, regular diameter. So first I decided to do the lower ones, easier to collect as much as cortical or autogenous bone I could have collected from the sockets. And then I filled those sockets with some xenografts and placed my 4 implants as per my planning. They were all parallel. These were the upper ones. As you can see here, I have a palatal approach to my cortical plate on the buccal side or facial side. And same here. This is the canine position. I went for the buccal side, 35-degree at an angle there, out. And I used a 35-degree multi-unit abutments on the anterior implants to make them parallel and straight, more on palatal. Because I never wanted, because I wanted a really cortical support there. So palatal bone never resorbs, it's quite cortical there. And I got my implants have bicortical support from a palatal cortical plate as well from the buccal cortical at the apex. And a posterior ultra short implants are placed. And then I screwed my procedure, picked up my impression with the dual core composite, milled it nicely, polished it, and placed it in my patient's mouth. Now, I'm sure the picture is not really great because I was tired by the time I finished this surgery, and I have a group of students there, colleagues there, were watching this surgery, and the patient had a panic shock, and he just wanted to leave the office. So I didn't have find much time to do some artwork there in the lower jaw. So I just have to place it because I knew the patient, if he leaves my office, is not going to come for next few days, and I might end up in failing my planning. So here you can see 2 implants from buccal to the palatal side and 2 ultra short implants. This is post 6 months when the patient come in, and then I relied my temporary processes for some time. I want to give some time to my ultra short implants here, and then a patient come back and I gave a bio-HPP framework with composite work on it. My ultra short implants are really doing very well here, and I had a lot of bone coming in here. Maybe one day I'll present this process protocol somewhere. There's another case. Fast, I'm covering it as a very beautiful case I want to share. I used here a tooth bone to create a bridge there, and I splitted the bone and used a tooth bone, third molar. I took it out and mixed it with the autogenous bone and created the ridge there. And then I decided to do immediate implant placement after placing the implants there. And I cut that implants and mesoblock there, and decided to make 2 customized abutments with glass, and then I give a temporary crowns over it for the lower ones. This is the customized abutment with glass, Emax, and 2 composite crowns over it. And I sent the patient with this. And the upper one, the patient is wearing a temporary crowns, and later on changed to Vita enamic. There's another case where we had a lot of customized abutments scanned and loaded in the same day. The patient came, we took an intraoral scan, planned, made a customized abutment and the soft crowns over it because the patient was a Braxer, and the guy is doing fine. There's another case where we had a fractured canine, and we did so maximum torque I'm using it here is about 40 to 50 max. That's a final torque. I'm not going beyond it. It's not required there. More torque I put it there, more complication I can have it there later on. And I use this tooth and partially demilitarized bone. I've used it and placed it in the socket itself just to see how this partially demilitarized bone tooth can help me to create a nice profile of my socket and canine. Here I use a natural central incisor. I just milled it because the patient was already wearing a bridge, and I placed immediate implant here, and I used bio-HPP framework and composite build up and gave a temporary to the patient. And this was the temporary. Later on, patient came in, I gave the patient a Emax crown, and that was the results. This was post 6 months result of the case. Now this is post 1 year, post 2 year. So it is working fine. And this was the recent when patient came just before the lockdown, because she had some problem here on my old implant which was placed some more than 10 years back. This patient was immediate implantation and immediate loading with a gestal approach sinus lift, and gave the patient a temporary, scanned it, and this same scan we made temporary as well as the final one. And when the patient came back next time, we changed it to the final one. So digitally it was viable for me to make both the crowns in one go. First was with the CAD cam, and the same design impression I used to make a customized zirconia abutment with a Emax crown. So both the job done. This was after 6 months when patient came, removed the temporary and gave the permanent. So if I look at here, post 2 years, the patient had a nice healed sinus bone. This was beta tricalcium, I think I've used there at that time. So I had a sufficient bone there. This case, I've done the immediate implantation and planned a zirconia framework with the PMMA crown there. Both the framework was splinting both the implants there. So this was the planning done, and 2 crowns made, splinted, and zirconia frameworks was sintered and cemented over the implants with 2 PMMA crowns. And patient came back. This was a post-surgery, the results. And the patient came back after some time, and I found some loss there. So I have to remove this process and re-cemented it. This is post 6 months. But then I realized the posterior implant not really doing well. I am finding some bone loss on the distal implant. So I changed that framework, and I gave a bio-HPP framework with composite crowns. The patient is doing much better now and is fine. This is a tricky case. The patient had a fractured framework, zirconia framework. So hardly had any bone in patient's mouth. So we planned it, virtual planning done, and then we started with, this was the virtual planning there. So as per her old occlusion, we just mounted the upper and lower models, and then I planned the virtual teeth there and prosthesis, save them as a catalog. That's the same, the lower one. And then I planned my implant wherever I got the bone, and within it's allowed me to have a angulated multi-unit abutment not beyond 30-degree angulation and depth. I planned my implant wherever I had the bone there. So all the implants in different angulations, some from palate to the buccal side, some are in extraction socket. If I go back, as you can see here, I place it very, very nicely in between the cortical bone. So this was the planning done to have as much as cortical support, bicortical support. The implant was from the palate to my buccal cortical, or I would say a triangle there, and I planned those cases accordingly. Surgical guide made after superimposing it, and upper and lower surgical guides were fabricated and milled. These were the 2 guides made. As you can see here, there's some weird angles here, but this is all because to have a cortical, bicortical supports there. This was the surgical pictures. Some granuloma here, we remove, luckily debrided everything. Place my implant as I have to plan it. These were 5 implants placed, as this was the temporaries, milled and layered with lab composites, and placed on the same day. Actually next day morning, because patient was tired, so we placed upper and lower next day morning. this was the implants placed exactly how it was planned. And this was the final bridge given to the patient after 6 months. It was too pink, so we called the patient after some time, and we sandblasted the composite that changed to the lip color. This is also a partial case. Again, here I use the implant from immediate implant through the socket. I don't want to do a sinus lift, so I had some palatal bone here. So from the buccal side, I went into the palatal side to get the support, bicortical support, and that was only special implant in that case. And we removed only one segment. So here I'm restoring only one segment here, and the lower I'm doing the full all-in-4. Wax up, trial in patient's mouth, cataloging it, place my implant there. So this planning, I cataloged it in my software. So I saved this planning virtually, scanned it, and then I placed my implants, picked up my impressions, did the upper implants, placed 3 implants, collected some bone, mixed it with the collagen with xenograft, and placed into the sockets. And then temporary was fabricated, milled, and laid it with bit of gum-colored composites and sutured, screwed in the patient's mouth. This was the occlusion what the patient had, and sent back home. And later on, he came. This was when we finished. This was 3 a.m. in the morning because it took me some time to finish. And this was the final. The lower one was done rigid splinting with whirling, and the upper one was milled. And this was the final crowns made on a bio-HPP framework with composite, and the lower one was again with the bio-HPP framework and composite crowns. And these were the situation and loaded. This was the final one. This is my last case, and I don't have the CPCT of these cases because this I just loaded today. The patient had a fractured front anterior teeth. 2 teeth were fractured, and because of the reduced posterior bite, this was fractured. This was restored somewhere about 20-25 years back with some silver amalgam buildup, and I removed the roots, cleaned, debrided the sockets. This patient was a highly chain smoker, and we have to give him a 2-month grace period that if he stops the smoking, then we'll do it. As you can see, the smoker's palate here. So guided surgery we planned, and 4 implants placed as per the plan. More palatally it was placed, and the buccal jumping distance was with the xenografts been restored, parallel. Picked up the impressions. Again, the problem was here, the scan posts were not scanning it well. It was getting a little submerged and blood was coming in, so I couldn't scan it well, so I had to pick it up with the analogs. And then this was the temporary presentation superimposed on the impressions, and temporary was made with the PMMA, milled and cemented there. With the old occlusion plan we did on the patient, we immediately load the prosthesis. And the patient had a little funny bite here because I have to make it more proclined, so there should not be any load on my teeth there because a lot of grafting was done. The patient came back after 2 months. This was the tissue healing here, nice tissue healing. I was happy with it. And there was a little, as you can see here, I was feeling a little gap there. But that was unfounded, so when I removed the bridge, it looked fine to me, nice healing there. And then I picked up the impression. I did actually a full mouth rehab in this case. I corrected the vertical height posteriorly and corrected the occlusion there. Now we have a nice bite here, a nice overjet and overbite here. This was the final crowns fabricated, and this was the final soft tissue profile, and final crowns placed on the same day, means after 2 months. This was after the same day when I put the final prosthesis, and this was after 6 months. It was really keeping it very well. And this is in 2019 November when the patient came. It looks nice to me. It was walking, the gums were walking in between the gaps which I created on the ceramic, and this was his final smile. This is just before the lockdown when he came for a checkup. Actually, he came for cleaning and maintenance. So I'm very happy with the soft tissue results there. This is my small office where I work. Really, thanks for the patience. And I have a small office where I work in and small team. These are the ladies of in my life. This is my younger one. She's in Canada right now, and she's the other one. She's in Boston, and they're grown up now. That's my wife. These are the ladies. What makes my life worth. Thank you. Stop comparing yourself with other people. If they are good at something, you are too good. And you are also good at something. Self-confidence is not measured by other capabilities versus that of others. Thank you. Jai Hind.
Thank you so much. Okay, Dr. Lamba, one moment. I think there's some
I'm
questions.
lost my time. Really sorry for that.
No, not at all. Thank you so much. Okay, let me see. Are you able to see the questions or you want me to read it?
I can see that. Dr. Sachin, the talk I just mentioned in between, I think if you were hearing it, thing is that the talk, initial talk or the final talk, I keep my initial